Okay. John, his email is Poland.
Spell that.
Poland.
He said he's getting it now. It's Poland, Poland .Gregory at mayo.edu. But
Okay.
I sent it to his Gmail. Oh, there you are. Hi, Greg.
Oh, there we go.
Thank you for coming.
Yeah.
I gave you your curriculum vitae, and you're ready to roll anytime you want to talk. We got about 37. We got about 37 people today.
Let's see. Whoever the host is, you need to enable screen sharing so I can.
Sure. Okay, you should be able to share now.
Are you able to see that?
Yep.
Okay, so I'll go ahead and get started here. I'm going to talk about the, 5 or 6 M's here: myths, mysteries, misinformation, myopia, and miracles. So a lot to cover. One of the first myths, this is almost intolerable to us as healthcare workers, as we see the number of Americans who die increase by the tens of thousands. Nonetheless, there's the continuing myth that COVID-19 is a minor disease like the flu. That's an extraordinarily ignorant opinion if you hear anybody express that. I think somebody needs to go on mute.
Yeah, if everybody would go mute themselves, that would be great.
Yeah, you can do that for everybody, whoever's running it. I'm not sure how it's done, but I know that I've been on Zoom meetings when one person just puts everybody on mute, the one that's in charge of it. But maybe it's been handled. Okay.
Opinions that it's not spread by the respiratory route, or that masks don't work, or that it's going to disappear, or that it somehow magically only harms the very elderly. There are also some mysteries. This virus is exquisitely well adapted to cause human infection and transmission. It triggers an immune response that impacts virtually every organ system. And it causes an incredibly wide spectrum of morbidity and mortality. And one of the mysteries is human irrationality, which we'll come back to. Some of the more common misinformation, and remarkably, I mean, I think somebody still has something open and we're getting reverberation. Remarkably, people who have spent no time in their life in the science of this express strong opinions, and that opinion is resistant to the scientific data, which of course is irrational. Some of those are that masks don't work, that this is some kind of government attempt at control. I know some of these are laughable, but this is what I get, that there are nanobots and microchips in the vaccines, that the mRNA vaccines are going to alter our chromosomes. And the reason for this is that people with relatively low cognitive complexity conflate political, religious, and their own economic conflicts of interest with evidence-based pandemic response. Whoops, what happened there? In terms of myopia, we have clearly failed to contain the virus. Our pandemic response has been a miserable failure. We have not had a national level science-based pandemic response. And a large swath, a shockingly large swath of the US population has rejected science-based recommendations. There has been a denial of reality. Ignorance is one of the most highly transmissible diseases in humans. You've heard overpromising. difficulties with developing common protocols, and at the government level, funding that only lasts as long as the human attention span, which is why, despite this being the third time a virus like this has crossed the species barrier in 17 years, that we were not even more prepared. The miracles are that we have a safe and effective vaccine, and we're going to have more, all within 9 to 12 months after discovery of this virus. That has never been done in humankind before. The other thing is that case fatality rates could have been even higher. And of course, the amount of international scientific collaboration that's occurred. The result is that we have reached a phase of exponentiality, and I want everybody to understand this. We can no longer control exponentiality. It is not possible. Exponentiality in any field of endeavor has never been able to be controlled by humans. This is no longer controllable by contact tracing. The numbers of infections and cases are too massive. There is only 3 ways in which this pandemic can now be controlled. The one is a hard lockdown with mandatory masking, with hefty fines for non-compliance and distancing. You've seen one country after another have to go this route. It works, but at a cost. Or the virus mutates to be less transmissible. That has not been happening. The opposite has been happening. And finally, a high efficacy vaccine that would be accepted and used by 70, 80, 90% of the population. Because of the scientific illiteracy in our society, none of these are likely to work the way we had hoped. And so this pandemic will continue. The result of this is in the 7-8 days following the election, 1 in every 400 Americans became infected. 1 in every 11 infections is now in a child. Impossible to imagine case counts now that are exceeding 200,000 new cases a day. We add 1 million new cases every 4 or 5 days. We have now 104,000 Americans hospitalized with COVID. Since February, and by this coming March, 1 in 700 Americans, hear me clearly, 1 in 700 Americans will be dead from COVID, a virus we know how to control with something as simple as masking and distancing. George Bernard Shaw said, "We learn from history that men never learn anything from history." So what about the vaccines? I'm going to do these at a pretty high level so that we leave time for questions. There's lots of them in clinical trials. The FDA will meet tomorrow. I have already reviewed all the briefing documents, and I'll go over those. We right now have no vaccines licensed in the US. There are multiple vaccines in development. The reality is that it'll be 3 to 9 months before everybody has a shot at getting the vaccine. So there are attributes of ideal vaccines. These are the ones that we will meet with these current vaccines. Excellent safety profile, can be quickly mass produced, stimulates a balanced immune response, and doesn't cause any pathology after vaccination. These are the ones we won't meet. It will not be stable at room temperature. We will need cold and ultra cold chains to store the vaccines. We can't store them indefinitely. So people will have a shot at the vaccine. If they turn it down, they lose their opportunity. We will not have mass administration mechanisms that don't require highly trained healthcare providers. And it won't induce protective immunity after a single dose for most people. This is a bit of a nuance, but we don't yet know about the ability of the vaccine to protect against asymptomatic disease. it does prevent symptomatic disease and complications. Now, I won't get too detailed here, but all of you hear about the spike protein. So this is a lipid-enclosed RNA virus. They are exquisitely sensitive to being inactivated by simple things like soap and hand washing. You cannot get infected with this virus if you wear a proper mask properly. Wearing it below your nose is a sign of ignorance. And if you're distanced from people, you cannot get the virus if you're doing those things. The vaccine is produced against this spike protein. We are not giving the whole virus. You're giving this piece of the virus. It cannot affect your chromosomes. It does not cause infection. It causes an immune response against that piece of the virus. So the first one that we'll talk about is the one that will start being used prior to the end of this year, called an mRNA vaccine. That stands for messenger RNA. What it is a series of letters, a code to produce that S protein. That code is transported into our cells and translated into the protein. This is the blueprint for the protein that's made. Once that protein is made, then our immune cells think that it's the coronavirus and produce an immune response against it. There are two of them, Pfizer, which will be reviewed tomorrow, and Moderna, which will be reviewed a week from now. The Pfizer vaccine requires 2 doses, 3 weeks apart, has to be stored at 104 degrees Fahrenheit, lower temperatures than Antarctica, in order to remain stable. They don't inject it into you that cold, they inject it into you at room temperature. Has mild to moderate reactogenicity. You're going to hear about side effects like you do with every vaccine. This is important to understand. These side effects are symptoms of the vaccine working. So yes, it causes a sore arm, low-grade fever, maybe fatigue or headache, or feeling wiped out for half a day. That's a sign that your immune system is making a vigorous immune response. That's a good thing. What we know is that the vaccine was 95% effective in preventing symptomatic disease. That is as good as or better than any vaccine that we have. The Moderna vaccine is also a 2-dose vaccine, 4 weeks apart, and basically the same level of efficacy. Now, both of them require a cold chain, but the Moderna not quite as cold. Now, I'm going to show you one piece of data. This came out in the New England Journal of Medicine late last week. These are 34 subjects, and you can see 18 to 55, all the way to people over the age of 70. And what you see is that every single person who got 2 doses developed protective immune responses. But what you also see is in this column of people over the age of 70, that their antibody titers tended to wane faster than younger people. That's why you need 2 doses, and it's why likely we'll need to get boosters in the future. We don't know that for sure, but that's likely. These are the cold storage requirements, and you can see that Moderna's -20, Pfizer -75. but you take it out of that storage and you put it at room temperature. For the Pfizer vaccine, you got to use that within 2 hours. With the Moderna, 12 hours. So you can see if it's your turn to get the vaccine and you decide, nah, I want to wait, you're not going to get it until much, much later. And that represents a risk to your health and your life. The next set of vaccines are what are called adenovirus vectored vaccines. So everyone listening to me has been infected repeatedly with adenoviruses. It is a common cold type virus. What they do in this is they take that blueprint for the S protein and they put it inside the genetic material of this virus. You inject the virus, that blueprint gets translated into that S protein, and your body develops an immune response against it. There are a number of those. The first one you're going to hear about is AstraZeneca. This is a common cold virus isolated from a chimpanzee. There's a Johnson & Johnson vaccine, and these just refer to different types of adenovirus. You've heard of the Sputnik V. It is not 5, it's Sputnik V for virus. This will not be used in the US, nor will the Chinese vaccine. So it's going to be these two vaccines that the majority of people are likely to have access to. All we have is press releases so far showing that the vaccine was about 90% effective in people who got a half first dose and a full second dose, about 60% effective in people who got 2 full doses. The reason for that is still being looked into. However, it did protect people from being hospitalized or having severe disease. The Johnson & Johnson, we don't yet have human data. We only have monkey data, and it worked very well in monkeys. 60,000 people are being enrolled in this study. The last category are protein-based vaccines. This is where you take this S protein and you use that as the piece that you're injecting. A company called Novavax is doing that. It works extremely well, produced very high antibody titers, still requires 2 doses. Now, the problem with all of these vaccines, in my opinion, I've been a vaccinologist for getting on 40 years, is that they are S-only approaches. That is, it's only the S protein. And the reason that's a theoretical concern is that this is what's called an RNA virus. RNA viruses mutate. They mutate at different rates, but they mutate. That's why the recommendation that every one of you get a flu vaccine every year, because that virus changes. So the question is, could the virus change such that getting a vaccine wouldn't protect you or wouldn't completely protect you? And the answer is yes, that's possible. Here's why. The anti-maskers and the people who don't want to distance have foolishly prolonged the pandemic. This is an example of all of the mutations that have been identified because of more and more people getting infected. Those green and red dots are mutations that, if you carry them, the monoclonal antibodies we have for treatment will not work in you. If you carry the purple or orange, then the convalescent plasma will not work in you. So this is extraordinary, appalling ignorance of how this pandemic has been handled, and we are beginning to see the consequences of unregulated transmission through a population. In addition, humans have spread this virus to mink, both in the US and in Europe. Those mink have altered the virus and spread it back to humans. In addition, in Europe and Oceania, 2 new strains have been identified called the 20A-EU1 and 20A-EU2. This one worries me. This has a mutation right next to the receptor binding domain, making it easier for the virus to bind to human cells, and that's not a good thing. This is now surging through Oceania and will come here because of our lack of following basic recommendations. So now what? Well, there are things we don't know yet. These very high efficacy measures, we don't know how well the vaccine will work when people aren't wearing masks. We don't have long-term safety data yet. And we don't know about the vaccine in groups that weren't studied, like pregnant women. But what we can say is that mask wearing, hand washing, and distancing must continue even after vaccination because of this. Now, how is this going to work? Well, physicians and scientists like myself will be the very first ones to roll up our sleeves and get vaccine. People in long-term care settings will probably be the next. Then high-risk elderly people, and finally the general population. This group is likely to not get immunized until this coming summer. So when you have a chance in line, my recommendation is take it. So I will stop there and then take questions. That was a very quick overview. So happy to take questions.
Any questions for Dr. Poland from our group of people attending the Zoom conference?
Dr. Poland, I have a question. How would you respond? How would you respond in your professional wisdom to the notion that this is an engineered virus and not an organic virus?
Yeah. You know, who ultimately ever knows, but there's been no evidence of this being an unusual virus, any different than SARS. In fact, it's less deadly than SARS or different from MERS. So this appears to be a zoonotic virus. That is a virus that developed in animals and jumped that species barrier.
Okay, I appreciate that. And just a follow-up question. Would I be mistaken to say that most viruses have a season and that they exist in varied, under certain conditions, but that generally speaking, they have a season?
Yeah, there is a seasonality to respiratory viruses.
Okay.
That's the caveat. Clearly, HIV, hepatitis has no season.
Right.
But from a respiratory virus point of view, you saw caseloads in the US during the summer of 20,000 or so a day. Now we're at 200 to 300,000 a day during our fall and winter season. And
Yep.
so this is why, you know, I went back, I talked to this group and I talked to the community back in February and March. And I went back and looked at everything I told you. Everything I told you turned out to be absolutely true, with one exception. I underestimated the number of deaths. I thought about 100,000 people would die. We're at 300,000. We will be this winter at 500,000. So people here with us right now are going to die as a result of ignoring science recommendations, and that will amount to about 1 in 700 Americans.
Okay, thank you very much.
I have a question. This is Peter Piro. I see lots of people walking around with quote unquote masks. They have a scarf over them, they've got a bandana, whatever the case might be. What is the prescribed mask that has the highest efficacy rate?
Let me grab one.
Okay.
All right. This is the neck buff or gaiter or bandana that you see. That might protect you against large droplets. So when you sneeze, you can see large droplets of mucus on your hand. It will protect against that. What it does not protect against is the small, what are called aerosolized virus that you can't see. If you wear this and you cough, the data shows that what you do is that you're taking the large droplets, forcing it through this porous material, fracturing the virus into a more contagious and more transmissible virus. Okay, what's next? This is a mask my wife made. She just took 2 layers of cotton fabric, cotton sheeting or Hanes men's t-shirts are the 2 best. And you cover nose and mouth. This is ignorant. This is stupid. I'm being very blunt because too many people are dying. I've been for 10 months burdened with one tragedy over another. We watch one family after another in the media say, after their father dies, for example, you have to tell people this is real, this isn't a hoax. It just happened with an Alabama senator who was convinced this was a hoax. Well, he died of a hoax, okay? And is telling his wife, get the word out. Because you see this does not help. Don't bother. The next best, the best one, and everybody can buy these. You can buy them at Aldi, you can buy them at drugstores, is what's called a so-called paper surgical mask. The blue goes on the outside. You see people wearing them inside out like this. They are built to filter this way. Goes over your ears, below your chin, above your nose, and crimped tight around your nose. This is the best common protection that you have. And I don't have one here. The very best is what's called an N95 mask. You can order those. The ones that have a valve in them, do not waste your money. Okay? Those are not helpful. And N95s are not that comfortable to wear. I can wear them for a few hours, after which they're not very comfortable to wear, and they have to be fit tested. I see people all the time wearing masks wrong. I usually will gently ask if they're interested in knowing that, in our society that can get you shot. But, I have an obligation as a physician, because these are people that I'm going to end up having to take care of, telling me that it can't be COVID. It must be something else because COVID doesn't do this. Well, sorry, buddy. Yes, it does.
Dr. Poland,
This is Bill Flashy. I think everybody in our club is over the senior level and may qualify for the 3rd round.
Yeah.
Many of us are also snowbirds. We spend seasons in Marco and summers up north. I am concerned about where we would qualify to get the vaccine. Do we need to be in our northern states in order to get this, or can we be out of our northern states and Marco and still be able to qualify to get the vaccine?
That's a very good question, and I frankly don't have a clear answer on that. That question has come up a lot. Let me call it micro details of the distribution and allocation plan have not been made available at that level, and in part made more difficult because each state will decide that. So I don't know yet what's going to happen in Florida, whether you'll have to show residence or just fit into the risk group that vaccine will be available for. I don't know.
Thank you.
Dr. Poland,
Doctor, I have a question for you. It's if you have an autoimmune disease, okay, can you take this vaccine if you have an autoimmune? Because I have there's a guy in the men's club that just came down, and I'm talking with him about it, and he says, I can't take the vaccine because of that. Is that correct or not?
So let me first talk about a principle, okay? So there is nothing in any aspect of your life that is 100% effective or 100% safe. There's nothing. Your car, drinking a glass of water, nothing. It's just the nature of how things work. So a smart person says, what's the balance of risk and benefit, knowing that there is both for everything we take. You take, if from what you described to me and looking at the audience being generally older men, probably almost all of you are taking some kind of medication. That medication has benefits, which is why you take it, but it also has risks or side effects. But you're balancing the two. Now, when it gets to a vaccine, what do you do? So there is no evidence that this vaccine will trigger an autoimmune or worsen an autoimmune disease. Could it theoretically? We have to say yes, it could. We haven't seen it in 70,000 people who have gotten immunized, receiving 140,000 doses. But is it 1 in a million chance? Sure. But then what you have to do is say, okay, let me just accept there's a 1 in a million chance. There's a 1 in 700 chance I'm going to die if I don't get this vaccine. So which one would you take?
Yeah.
And that's unfortunately the balance of thinking that people are going to have to do, I hope in association with their healthcare provider, and not just blindly make fear-based decisions.
Yeah. By the way, I see John Rayner has joined the group here. He's one of our men's club guys. John, weren't you in the Moderna study?
I was going to ask a question about that. Yes, Randall. And Doctor, a question for you. I am in the Moderna study.
Yeah.
So I've had my 2 injections. I don't yet know whether I got the placebo or the vaccine.
Right.
My understanding is that when a vaccine is approved, that they will unblind the study. So the 2 questions I really have, and I don't know if you can answer these or not, it was set up as a 2-year study. Do you think Moderna will continue to follow me for the full 2 years?
Yeah.
And secondly, when the vaccine becomes available, I'm not sure, they said they would offer it to me, but was unclear as to when. I don't know if I get to jump ahead in line or I wait for my age group. I just don't know. I don't know if you can answer either of those.
Yeah, well, first of all, thank you for joining the study. There always have to be those of us that go first, or we never make scientific advances. So thank you for that. That is a magnanimous gesture. The practical part of your question, which is a very good question, is we don't know yet. Now, I'll tell you the tension. What the people who enrolled in the study want to know is, do I need to get the vaccine? Because maybe I got placebo. For those of us looking at the broad population level, we are trying to convince the companies to not break the code yet. Because once you break the code, you can never go back and you can never gather those data again without doing that whole study over again. So when people say, well, wait a minute, you only have 2 months of safety data. We're actually getting close to 3 now in some of the participants. If we unblind the trial, we'll never have that data beyond that. Whereas if we continue the trial, we will have those data. And here's why. 1 year ago, in this same week, there were X thousands of people who look like you and me who had a heart attack, a stroke, who were diagnosed with Parkinson's, who, all the things that happen medically. Now move forward a year to this year. That same week, everybody who gets a vaccine, by chance, is going to have those same things happen. But what do you think they're going to blame it on? Right? If they got a vaccine yesterday and had a fever and have a heart attack tomorrow, what are they going to blame their heart attack on? That's why you need the placebo group, because you're looking to see, do things like that happen more commonly in the group that got the vaccine, or with the same frequency as people who got the placebo? And once you break that code, you don't know. So we know data now up to about 2 to 3 months, but people are asking for data longer than that. So my hope is that they'll reach a compromise, John, where they'll say, hang on for another, few weeks, month, 2 months, and then we'll break the code and give you the vaccine.
Dr. Poland, if 10 to 20% of the population never gets vaccinated, what does society look like in 2 years or a year and a half?
Yeah, well, here's the complexity of it. So I'm just looking around. Maybe I'm the youngest one sitting here. I'm 65. John, I can't tell. John D'Amato, I can't tell. Maybe you're younger than me. I can't tell. But all of us are considered, you're not going to like the word, all of us are considered immunosenescent, meaning that our immune systems don't work the way they did when we were 30, okay? Hopefully everything else is working the way it did then, but probably not. But so what's likely to happen is in the older group, our antibody levels are going to wane faster than the group of people who were in their 30s. So what it means is that the vaccine may wear off, so to speak, at different rates in different people. That's point one. Point two is that the polls are showing 20 to 40% of people aren't going to accept the vaccine. There's point two. Point three is that even in people who do get the vaccine, it's likely that somewhere around 5 to maybe at most 10% of them are not going to respond. They're not going to be protected. Point four is that you have, and it's different in different geographic areas, you have people who have been infected and at least are temporarily protected. So you have to take the mathematical distribution of all four of those points across time to know what's going to happen at any given point, how many people are susceptible. That's why I say my prediction is that until we get very high numbers of people to take the vaccine and know what protection is a year and 2 years from now, which we can't possibly know right now, we're going to have to wear masks.
Warren Yule with a question. Doctor, I had it, my wife had it. Me very mild, her very significant. What's the chance of reoccurrence or reoccurrence in a time frame?
Yeah, sorry you got it, but glad I trusting both of you are okay. The answer to your question is unknown. Here's what we do know. People who had symptoms of COVID had a positive test, so we know they had COVID, then recovered. Later, 5+ months later, got re-exposed, got reinfected, had symptoms, and documented tests. So we know that reinfection is possible. All of that has occurred in a time period when the virus hadn't changed very much. My concern is that we are seeing rapid mutations because of so many people getting infected. Every time this virus infects somebody is an opportunity for the virus to mutate. So the more people, and I mean, it's unbelievable. We're having yesterday 288,000 new infections, and that is an underestimate. That's only the people that went in and got tested. So as you passage this through more and more people, more and more mutations will occur to the point where people previously infected won't be protected. They'll be susceptible again. That's more likely in older people. It's more likely in people who are immunocompromised, either because of a medical condition they have or because of the treatment that they're taking, like steroids, for example.
Doctor, I understand that North Dakota has a breakout of like 1 in 10 coming down with COVID-19.
Yeah.
Is there anything that standardized protocol for treatment, given the amount of time that has passed? And if so, for example, the cocktail that Trump had, maybe Juliana, are not generally available to the rest of us. So what's happening on that level?
So what happens is, and again, it depends on geographic location. One of the things that will be, I privately have said this is going to be a massacre this winter because we have hundreds of thousands of people leaving the Northeast and the Midwest and crowding down into Florida. They are bringing their virus with them. Okay, they are doing that. No one of us thinks that it's us, right? It's other people, but they all flock down here, bring it. They're going to go back at Christmas time, come back again, just accelerating this. I mean, it's like putting gasoline on a fire. So vaccine doses and monoclonal antibodies and convalescent plasma and numbers of doctors and nurses is fixed. Just because Marco Island goes from 15,000 to 60,000 doesn't mean we get more doctors and nurses and masks and gloves and monoclonal antibodies and convalescent plasma. It's fixed. So that's why when you see these surge demand on the hospital system, if you go to the dashboard of El Paso, Texas, 2 days ago, their dashboard said number of hospital beds available, -5. They're setting up beds in the garages of the ambulance companies. What do you think your quality of care is in that environment versus the ICU at NCH when there are 10 beds still available? Night and day difference. So what we do is we take the number of doses of whatever therapeutic we have, and we say, okay, you have to meet certain criteria. And this makes it logistically difficult. You have to be at high risk. You have to be infected, confirmed, but not yet sick enough to be admitted to the hospital or be on oxygen. That's a narrow window. And there will be some doses of monoclonal antibodies, which are very expensive, and convalescent plasma. For the others, it will be supportive care. It will be like being in the military and doing triage.
Doctor, have you all been trained in triage?
So that's a good question. There is nothing in the medical school curriculum or residency curriculum that trains you for that. What's happening is it's just in time training. So as these are happening, people are developing common protocols for what's going to happen. But, you know, I hate to say it, but let's just say you have 5 doses of something and you've got 10 patients that need it. And you've got a group of 40 and 50-year-olds and you have a group of 80-year-olds. What are you going to do?
40 or 50-year-olds.
You know, if I were the 80-year-old, I'd say, give it to the 50-year-old. Not everybody feels that way. And one of the things being talked about is it really fair for the people who have rejected all of the science-based recommendations and now get sick? Is it really fair that they go to the head of the line, so to speak, because of the severity of their illness? I mean, that's a broader discussion, but that discussion is starting to come as those of us that work in this field are positive we're going to be overwhelmed this winter, dramatically overwhelmed.
Thank you.
Dr. Poland? Are you aware of the timeline for the Johnson & Johnson, Janssen phase 3 trials?
You mean in terms of when they would come to the FDA?
Yes.
Probably not until, I'm going to say mid to late Q1 of 2021.
Okay, thank you.
Yeah, as far as the protocol for who gets the vaccine, maybe you don't want to answer this question, but it seems to me that some essential workers like policemen, firemen, teachers ought to be way up in the next category, maybe even before us older guys. Have people, I haven't seen that seriously suggested. What do you think?
Yeah, there's been a lot of discussion about that, actually, both at the National Academy of Medicine and at the CDC. Recommendations will come out. There's going to be an emergency meeting of CDC this Friday afternoon, but each state gets to determine that. And you've seen things. I mean, look at our state and our pandemic response. Miserable. If you look at our own police department, how often do you see them wearing masks? This is just a tragedy. And if there's one message I could get across to you is you would never ask your grocery store clerk what to do about a mechanical problem in your car. Why would you listen to your neighbor or some untrained person or a politician about medicine and science? And I would plead with you, do not travel this holiday. I would plead with you, don't let people travel down here to have the holiday with you. I would plead with you, wear a mask and maintain distancing. Unless you've been a healthcare provider, you have no idea of the emotional impact of watching somebody drown in their own secretions and there's nothing you can do. It's a terrible way to die.
Yeah, but what about the priority of quasi-essential workers like police, firemen, and teachers?
That's what I said in the beginning, is each state will get to make those decisions.
Well, what do you think is appropriate if you had to make the decision?
Well, I think that the front-facing healthcare workers should be number one. When we go in to see patients, we are voluntarily risking our health and our family's well-being by taking care of people. That's what we pledged to do. I understand that risk, and I signed up for that risk. I think next is our military. I think then you begin to talk about other groups. Now, remember, you're a police officer. Yes, you have some level of risk, but you could also choose to wear a proper mask properly and diminish dramatically your chance of getting infection. Not eliminate it, I understand that, but diminish it.
Okay, thank you, Greg. I think we'll have one more question and then we'll close it off. I know you have things to do and I really appreciate you coming and speaking to the men's club again. And all I can say is that we're trying to, at least my family is trying to wear a mask and do the right
Well,
thing.
You know,
The only
I'm-
thing,
I'm-
the only thing scarier to me is seeing somebody die as you're standing at an operating table and they have a coagulopathy and they're bleeding out on you when the blood is like water. That
Yeah.
scares the shit out of me. But
You know, I
this is
mean,
bad.
ask your friends that don't want to wear masks. Are you okay with your doctor operating on you without a mask?
Yeah.
One of the observations I'd like to make is that for the standing of importance to society, I think the doctors and healthcare people should be at the highest level, especially during this pandemic. Why would you subject them first to experimental procedures? I would think you'd go with prisoners and old people.
So you can't, it's against the law to engage prisoners in experiments with very few exceptions. The second thing is that we don't consider it experimental. You've gotten a series of vaccines that were never tested in as many people as these vaccines have been tested in. That doesn't mean they're perfect, but it means we're confident. And let me just say one other thing, because I know everybody has their own opinion. If you were my brother, my father, my grandfather, my uncle, I would tell you this: get a COVID vaccine. If you have not yet gotten the high dose influenza vaccine, get it. If you have not yet gotten your pneumococcal, your pneumonia vaccines, get it. If you have not gotten your pertussis vaccine, get it. If you have not gotten your shingles vaccine, get it. Those are the things that are going to get you this winter.
Thank you.
Okay. Thank you, Greg, again for talking to the men's club. We'll let you go. And God bless you for your work.
Thank you.
And,
Excellent presentation.
I hope you'll excuse or give grace to the force with which I'm speaking, because we know no other way at this point. We are exponential, and there's nothing we can do about it now other than to basically plead with people to what you see us doing so that we save lives.
just to remind everyone, this presentation will be on our website, hopefully within the next day or so, and you can review that or have your friends review it, this excellent presentation, and hopefully could spread the word for the people here on Marco Island. And at this, we'll close off and leave the meeting, and thank you very much.
All right. Bless.